In 2024, a team of researchers from the University of Southern California published something in the Journal of Clinical Investigation that most doctors have never read. They discovered that your kidneys have hidden repair cells, cells that can rebuild damaged tissue, generate new blood vessels, and regenerate the lining that filters your blood. These cells are sitting in your kidneys right now, waiting to be activated. The problem? The average American diet has been keeping them switched off for years, possibly decades. I'm Dr. Harris. I've been practicing clinical medicine for over 15 years. Before I go any further, I need to be direct with you. What you're going to hear today is educational information based on peer-reviewed science. It is not a substitute for medical care. If you have diagnosed kidney disease, if you're on blood pressure medication, if you're managing diabetes, please bring this information to your doctor before making any changes. What I'm sharing today is the conversation you should be having in that office, and usually aren't. Here's what the standard narrative gets wrong. Your doctor orders a creatinine test at your annual physical. The number comes back in the normal range. You're told your kidneys are fine. You leave the appointment and go about your life. What your doctor did not tell you is that creatinine, the test that's been the backbone of kidney assessment for decades, doesn't rise noticeably until you've lost 50 to 60% of your kidney function. By the time that number moves, the damage is already extensive. The kidneys have been compensating so effectively that nothing showed up on paper until well over half the filtration capacity was gone. The Centers for Disease Control reports that 37 million Americans have chronic kidney disease. 90% of them don't know it. 9 out of 10. That is not a rounding error. That is a systemic failure of early detection. And it's happening disproportionately in people between 45 and 65. Where kidney function is already declining naturally, roughly 1% per year after age 40, and where high blood pressure and elevated blood sugar, the two leading causes of kidney damage, are quietly accelerating that process. If you've been watching your blood pressure, managing your weight, doing what you're told, and still feeling like something isn't right, fatigue that won't quit, blood pressure that won't fully stabilize, energy that drops in the afternoon, this video is for you. Not because something is catastrophically wrong, but because the map you've been given is incomplete. Today I'm going to walk you through what the research actually shows about how your kidneys repair themselves, what the conventional system has been getting wrong for years, and what specific foods have documented molecular mechanisms for activating the healing processes that may have been suppressed in your body for a long time. If this is the kind of information you've been looking for, subscribe. I publish this because it should be in every doctor's office, and it's not. No products, no sponsors, no agenda other than the research. Let me start with what the conventional system tells you about kidney health and where the evidence says that story breaks down. The official guidance from the National Kidney Foundation has been consistent for years. Manage your blood pressure, control your blood sugar, reduce sodium, avoid NSAIDs. That's the protocol. And every one of those recommendations is correct as far as it goes. The problem is not that the advice is wrong. The problem is that it treats the kidneys as passive organs that can only be protected by reducing insult to them. The underlying assumption is that kidney damage is essentially irreversible, that the best you can do is slow the progression. That assumption was challenged in a significant way when researchers at USC, working alongside teams from Michigan, Oxford, Johns Hopkins, and Yale, published their findings in the Journal of Clinical Investigation in 2024. What they documented changed the way I think about kidney physiology. They identified a population of cells in the kidney, cells in a structure called the macula densa, that function like a regenerative control center. When conditions are right, these cells secrete signaling molecules, recruit stem cell-like progenitors, and actually rebuild damaged kidney tissue, new blood vessels, new interstitial cells, new epithelial lining. The regenerative capacity was real, it was measurable, and it was directly regulated by something as simple as sodium availability. The research showed that when sodium intake was reduced, the macula densa cells became active. They started producing factors that triggered repair. When sodium was high, the way it is in a typical Western diet, where the average daily intake runs around 3,400 milligrams, more than double the recommended level, those same cells went quiet. The repair system was functionally turned off. The conventional system tells you to reduce sodium for blood pressure. What the conventional system has never told the general public is that excess sodium may be actively suppressing the kidney's own built-in repair mechanism. Those are not the same message. One is about downstream cardiovascular effects. The other is about whether your kidneys are capable of healing themselves or not. Now, to be precise about this research, it was conducted in animal models with genetic tracing. The macula densa cells have been confirmed in human kidneys, and the authors identified similar signaling pathways in human kidney tissue analysis. But the direct interventional proof in humans has not yet been established in a randomized controlled trial. The signal is compelling and the mechanism is plausible. The full clinical translation is still ahead of us. I'll tell you when I'm on solid ground and when I'm extrapolating because that distinction matters. What does have robust human data is the relationship between dietary patterns and long-term kidney outcomes, and the evidence there is striking. A pooled analysis published in the British Medical Journal in 2023 brought together data from 19 separate cohort studies across 12 countries, 25,570 participants, average follow-up of 11 years. What they measured was not dietary recall, which is notoriously unreliable, but blood levels of marine omega-3 fatty acids, EPA, DPA, and DHA. These are objective biomarkers of what people were actually absorbing. The finding: participants with the highest blood levels of marine omega-3s had an 8% lower risk of developing chronic kidney disease. Those with the highest DHA levels specifically showed a meaningfully slower annual decline in their eGFR, the measure of how well their kidneys are actually filtering. Here's the part the standard advice misses completely. The protection came from marine omega-3s, not plant-based omega-3s. When they looked at ALA, the omega-3 found in flaxseed and walnuts, there was no statistically significant protective effect on kidney function. The system tells you to eat healthy fats. It does not tell you that the specific type of fat has entirely different mechanisms of action in kidney tissue, and that taking a flaxseed supplement while skipping the sardines is not the same intervention. The research continued. A prospective cohort study from the ARIC trial, Atherosclerosis Risk in Communities, published in the American Journal of Kidney Diseases, followed 14,982 participants with a median follow-up of 23 years. They calculated a dietary adherence score based on two separate dietary assessments. What they found after controlling for blood pressure, diabetes status, BMI, smoking, and over a dozen other variables was that participants with the lowest adherence to a diet high in vegetables, fruits, legumes, nuts, and low-fat dairy, and low in red meat and processed meat, had a 16% higher risk of developing chronic kidney disease. The hazard ratio was 1.16, with a confidence interval of 1.07 to 1.26. That is a statistically solid signal across 23 years of follow-up. 23 years. That means what you are eating between the ages of 45 and 55 is determining the condition of your kidneys at 70 and beyond. The research didn't stop there. A 2025 meta-analysis in the Journal of Renal Nutrition compiled data across multiple studies and found that a healthy plant-based dietary pattern was associated with a 25% lower odds of developing CKD compared to omnivorous patterns. The odds ratio was 0.75 with a 95% confidence interval of 0.65 to 0.86. The mechanism driving this, which I'll explain in detail shortly, comes down to what different protein sources do to the mechanical pressure inside your kidney's filtration units. And then there's the research that gets almost no attention from primary care physicians, the work on anthocyanins and kidney tissue. A 2022 study published in the Journal of Translational Medicine used a well-validated animal model of diabetic kidney disease, the DB mouse model, alongside comprehensive proteomic and metabolomic analysis. The researchers administered cyanidin 3-O-glucoside, the predominant anthocyanin in blueberries, blackberries, and black grapes. What they measured was the effect on the primary molecular pathway that converts healthy kidney tissue into scar tissue. That pathway is called TGF-beta1 through SMAD signaling, and it is the dominant driver of renal fibrosis, the process by which damaged kidneys gradually replace functional cells with non-functional scar tissue. The anthocyanin treatment produced measurable reductions in glomerular lesion area, a reduction in fibrosis scoring, a drop in fasting glucose, and clear suppression of the NF-κB inflammatory pathway. The compounds driving this effect are sitting in half a cup of blueberries. The same molecular target that pharmaceutical companies are spending billions of dollars trying to reach with patentable drugs is addressable through the foods you can buy at any grocery store this week. That is not a fringe claim. That is the Journal of Translational Medicine, peer-reviewed, with quantified molecular outcomes. Now let me explain why all of this works the way it does. Because the mechanisms are what make the difference between following a protocol because someone told you to and understanding exactly what is happening inside your body and why it matters. The first mechanism is what I call the sodium suppression of the regenerative switch. The macula densa is a small cluster of specialized cells located at a specific point in the kidney tubule, the tube that processes the filtered fluid after it passes through the glomerulus. These cells are constantly sensing how much sodium is flowing past them. In the evolutionary context that shaped our biology, sodium was scarce. When sodium availability dropped, it signaled to the macula densa that the kidneys needed to work differently, more efficiently, more carefully. The research from USC showed that this low sodium signal doesn't just tell the kidney to conserve better, it activates a regenerative program. The macula densa cells start producing CCN1, a growth factor. They release nerve growth factor. They secrete angiogenic signals that recruit progenitor cells, precursor cells that can differentiate into the specialized tissues of the kidney. Think of it this way. Your house has a backup generator. The generator was built to activate automatically when the main power goes out. But if you've been running the main power continuously for 20 years, no outages, no fluctuations, the generator has never been tested, never been run, and the maintenance systems that keep it ready have never been triggered. The main power in this analogy is your sodium intake. The backup generator is the kidney's repair system. Reducing sodium is not just about blood pressure, it's about creating the biochemical signal that wakes up the generator. The second mechanism is what happens inside the filtering units of the kidney when you eat large amounts of animal protein. Each kidney contains roughly 1 million structures called glomeruli, tiny filtration units that are under constant hydraulic pressure. When you consume protein, especially animal protein, the kidneys increase their filtration rate to handle the byproducts. Amino acid metabolism from animal proteins generates sulfates and phosphates that require renal excretion. To manage this load, the glomeruli increase their filtration pressure. This is called hyperfiltration. And in a young, healthy kidney with full nephron reserves, it's manageable. But by the time you're 45, you've already lost roughly 10% of your nephrons through normal aging. The glomeruli that remain are already compensating for the ones that are gone. Running them at 130 or 150% of their baseline filtration pressure day after day, year after year, causes mechanical stress to the delicate capillary walls inside each glomerulus. Over time, that stress causes the walls to thicken, to become leaky, and eventually to fail. This is the engine analogy I use with patients. If you have a 4-cylinder engine and 2 cylinders are already underperforming, and you run the remaining 2 at red line all day, every day, the timeline on engine failure compresses dramatically. The plant-based protein pattern doesn't eliminate the need for protein. It changes the metabolic byproduct profile such that the filtration load is substantially reduced. The 25% lower CKD risk in the 2025 meta-analysis is, in significant part, this mechanism at work over decades. The third mechanism is what I call the gut-kidney toxin pipeline. Most people know the microbiome influences digestive health. What most people don't know is that when your gut bacteria are out of balance, when dietary fiber is low and animal protein is high, specific bacterial populations proliferate that produce compounds called uremic toxins. The two most clinically relevant are indoxyl sulfate and p-cresyl sulfate. These molecules are absorbed from the gut into the bloodstream and then have to be cleared by the kidneys. And as they're being cleared, they cause direct damage to the cells lining the kidney tubules. They trigger inflammation, they promote fibrosis, they accelerate exactly the same scarring process I just described. The 2024 analysis from the CRI study, the chronic renal insufficiency cohort, which follows patients with established CKD, found that whole grain intake correlated with better kidney outcomes, and part of the mechanism runs directly through the gut microbiome. The fiber in whole grains feeds bacterial populations that produce short-chain fatty acids instead of uremic toxins. Short-chain fatty acids, acetate, propionate, butyrate, maintain the integrity of the gut lining, reduce bacterial endotoxin transfer into the bloodstream, and shift the entire metabolic output of the gut away from compounds that damage the kidney. The gut is a factory. If it's running on whole grains and legumes and fermented foods, it's producing compounds that protect your kidneys. If it's running on processed food and animal protein with minimal fiber, it's producing compounds that slowly destroy them. That's not metaphor, that's documented biochemistry. The fourth mechanism is the fibrosis cascade. the process by which kidney tissue dies and is replaced by scar. The primary molecular driver of renal fibrosis is a protein called TGF-beta1. When the kidney is under stress, from high blood sugar, from inflammation, from the oxidative damage that accumulates with age, TGF-beta1 is activated. It sends signals through a pathway involving proteins called SMADs, and those signals instruct tubular cells to transform into myofibroblasts, cells that lay down collagen and connective tissue instead of doing the filtering work they were designed to do. Once an area of the kidney has fibrosed, that territory is functionally lost. The scar doesn't filter blood, it just takes up space where functional tissue used to be. The anthocyanins I mentioned earlier, specifically the cyanidin 3O glucoside found in blueberries, blackberries, black cherries, and black grapes, have been shown in the molecular research to suppress TGF-beta1 through SMAD signaling directly. They also inhibit NF-κB, which is the master regulator of inflammatory signaling in the kidney. When you eat a half cup of blueberries, you are delivering compounds that arrive in kidney tissue and interfere with the molecular machinery of fibrosis. The effect is not at the level of a pharmaceutical drug, but the mechanism is real and documented, and the cumulative protective effect of consistent intake over months and years is what the research is pointing toward. I'll tell you something I've seen clinically in 15 years that no clinical trial has randomized. The patients who come in with the best kidney function for their age are almost universally the ones who've been eating colorful produce consistently, not the ones who've been taking antioxidant supplements. The research supports that observation. A Cochrane review analyzing antioxidant supplementation in CKD, vitamins E and C, coenzyme Q10 in pill form, found insufficient evidence that those supplements improve kidney outcomes. The food form, with its full complement of cofactors and fiber matrix, behaves differently in the body than the isolated molecule in a capsule. The fifth mechanism is the oxidative balance of the kidney tubular cells. The cells that line the kidney tubules are among the most metabolically active in the human body. Every hour, your kidneys filter approximately 7.5 liters of plasma. Those tubular cells have to reabsorb 99% of what passes through: water, glucose, amino acids, electrolytes, which requires enormous continuous energy output. High mitochondrial activity means high production of reactive oxygen species, the free radicals that damage cell membranes, mitochondrial DNA, and the proteins that run every cellular process. When dietary antioxidant intake is inadequate, the balance tips toward oxidative damage and tubular cells begin to die. A 2025 study published in Frontiers in Nutrition used National Health and Nutrition Examination survey data from 2005 to 2018 to calculate what researchers call an oxidative balance score, an index that combines dietary and lifestyle pro-oxidant and antioxidant exposures. They found a clear inverse relationship between the oxidative balance score and the prevalence of chronic kidney disease after controlling for standard risk factors. The more antioxidant-rich the dietary pattern, the lower the CKD risk. This wasn't driven by supplements, it was driven by food pattern. The system doesn't connect these dots in a routine physical. You'll get a blood pressure reading, a creatinine, maybe an A1C. What you won't get is a conversation about which specific foods are driving oxidative balance in your kidney tubules, how the protein composition of your diet is affecting filtration pressure in your glomeruli, or whether your gut microbiome is currently generating the compounds that are accelerating kidney tissue loss. That conversation doesn't fit in 15 minutes with a prescription pad at the end. That's why you're here. Let me give you the protocol. What the evidence actually supports, in order of the magnitude of effect and the practicality of implementation. Before I do, and this is important, if you are taking ACE inhibitors or ARBs, drugs like lisinopril or losartan, the dietary changes in this protocol, particularly increasing plant protein and whole grains, can shift your potassium levels. Those medications already tend to retain potassium, and certain dietary adjustments can push that higher. You need to discuss this with your physician and consider having a basic metabolic panel repeated within 4 to 6 weeks of making significant dietary changes. If you're on warfarin, the increased intake of dark berries contains vitamin K, and the omega-3 supplementation has mild anticoagulant effects. Both require monitoring. If you're on diuretics, reducing sodium intake in combination with those medications can lower blood pressure more than anticipated. Monitor at home and talk to your prescriber. If you have stage 4 or 5 kidney disease, eGFR below 30, the potassium content of legumes and some fruits requires individualized guidance from a nephrologist. This protocol is designed for people with healthy kidneys who want to protect them, or people with early-stage kidney concerns in the eGFR 45 and above range. The first and most immediate priority is sodium reduction. Not for blood pressure reasons alone, though that matters, but because the molecular evidence suggests this is how you turn the regenerative switch back on. The target is below 2,000 milligrams per day. The average American is eating 3,400. That gap is almost entirely explained by processed and packaged food, restaurant meals, deli meat, canned soups, chips. The salt shaker on the table is about 10% of the problem. The other 90% is hidden in processed food. Read labels. If a single serving of anything contains more than 600 milligrams of sodium, that product is working against your kidneys. Swap one processed food per week. You don't have to do it all at once. But start now, because the animal model data suggests the repair signaling is responsive to changes in sodium within 1 to 2 weeks. You want that switch moving in the right direction as soon as possible. The second priority is marine omega-3 intake. The BMJ meta-analysis was unambiguous about the distinction between marine and plant sources. You need EPA, DPA, and DHA from actual fish, not ALA from plant sources. The target is 2 to 3 servings per week of fatty fish. Sardines are the most efficient source per dollar. High omega-3, low mercury, canned in water or olive oil. Salmon, mackerel, and trout all qualify. Wild caught where possible. Do not fry them. Frying oxidizes the omega-3 fatty acids and negates the benefit. Bake, steam, or eat them cold from the can. If you genuinely cannot eat fish, a pharmaceutical-grade fish oil supplement providing at least 2 to 3 grams per day of combined EPA and DHA is a reasonable alternative. Look for IFO certification or NSF certification and discuss with your physician if you are on any anticoagulant. Third priority is the anthocyanin daily dose. Half a cup of blueberries, blackberries, black cherries, or dark purple grapes consumed daily, fresh or frozen. The 2025 nutrition research confirms that frozen berries retain approximately 95% of their anthocyanin content. These can go into a morning smoothie, on top of oatmeal, alongside eggs at breakfast. The timing doesn't have a documented critical window. The key is consistency. Every day, not occasionally. The TGF-beta-1 suppression and NF-κB inhibition documented in the molecular research are effects of sustained intake, not acute dosing. Think of it less like a medication and more like a maintenance protocol. The analogy I use: the kidney's fibrosis machinery runs continuously. You want the molecular brake applied continuously. Fourth priority is the protein transition. You don't have to become vegetarian. You need to shift the ratio of animal protein to plant protein. The current evidence points toward replacing red meat and processed meat first. These have the highest metabolic acid load and the most consistent association with hyperfiltration. Replace one red meat meal per week with a legume-based meal, black bean tacos, lentil soup, chickpea curry. These are not compromises. They're delivering fiber for the gut-kidney axis, plant protein with a lower filtration burden, and a range of polyphenols with their own renal protective properties. Over time, work toward 2 to 3 plant protein meals per week. Don't worry about exact gram counts initially. The dietary pattern shift matters more than the calculation at this stage. Fifth priority is whole grain replacement, not addition, replacement. You're not adding oatmeal on top of your current diet. You're replacing refined grains with intact whole grains. White rice becomes brown rice or quinoa. White bread becomes whole grain bread with visible seeds. Instant oatmeal becomes rolled oats. The fiber in whole grains is what feeds the bacterial populations that reduce uremic toxin production in the gut. The Crick study 2024 data showed this matters even in people who already have reduced kidney function. The previous clinical concern about potassium in whole grains for CKD patients was being over-applied to patients in stages 2 and 3, where the benefit of reduced uremic toxin burden likely outweighs the modest potassium contribution for most people. Again, if you've been told to restrict potassium, discuss this with your doctor before changing your grain intake. Now here is the conversation you need to have with your doctor that probably hasn't happened yet. Ask for cystatin C. This is a filtration marker that, unlike creatinine, is not affected by your muscle mass, your protein intake, or your hydration status. It rises earlier in kidney decline. It is particularly more accurate in women, in older adults, and in people with lower muscle mass, exactly the population where creatinine gives false reassurance. Most physicians don't order it by default because it's not in the standard metabolic panel. It costs a small amount more, but it gives you a window into your actual filtration capacity that creatinine misses. Ask for a urine albumin to creatinine ratio, also written as UACR. This catches early glomerular damage years before eGFR starts to drop. The glomeruli becomes slightly leaky first. Albumin starts appearing in the urine in quantities below the threshold of a standard urinalysis. A spot urine UACR test detects this. Normal is below 10 milligrams per gram. Microalbuminuria starts at 30. By the time someone has a UACR of 300, significant damage has occurred that a basic urinalysis never would have flagged. Ask for serum uric acid. Hyperuricemia, elevated uric acid, causes direct tubular injury in the kidney, independently of gout. The threshold that most labs flag as abnormal is above 7.0 in men and above 6.0 in women. But the kidney protection research suggests the target for people concerned about kidney health should be closer to 5.5 to 6.0. If your uric acid is in the upper normal range, your doctor may not mention it. You need to ask. Ask for high-sensitivity CRP. This is a marker of systemic low-grade inflammation, the chronic background inflammatory state that's present in most people with metabolic syndrome, prediabetes, and early cardiovascular disease. It's also independently associated with kidney decline. A level below 1.0 milligrams per liter is optimal. Between 1 and 3 is elevated risk. Above 3 is high risk. The standard CRP test is too crude to capture this. You specifically want high-sensitivity CRP. Ask for 25-OH vitamin D3. Vitamin D deficiency is nearly universal in people with kidney disease and becomes more common with age in the general population. Vitamin D regulates the renin-angiotensin-aldosterone system, the hormonal system that controls kidney filtration pressure. It reduces proteinuria. It affects how the immune system interacts with kidney tissue. The laboratory reference range for normal is usually above 20 nanograms per milliliter. That's the floor for preventing rickets, not the target for kidney health. 40 nanograms per milliliter or above is what the kidney-focused literature points toward for optimal function. If you're below that, supplementation at appropriate doses, typically 2,000 to 4,000 IU daily, adjusted based on your level, is worth discussing with your physician. Let me talk about what to expect when you make these changes, because the research tells a clear story about timeline. In the first 1 to 2 weeks, if you substantially reduce sodium, most people experience a noticeable drop in bloating and water retention. Systolic blood pressure typically falls 3 to 8 millimeters of mercury in sodium-sensitive individuals within 2 weeks. This is relevant. If you're on blood pressure medication, watch your readings at home during this period. Your medication may become more effective, meaning your blood pressure could drop more than anticipated. This is a good sign but requires monitoring. The kidney regenerative mechanisms take longer to manifest than a blood pressure response. By the end of the first month, if you've maintained the full dietary protocol, research on similar dietary interventions shows that urinary albumin excretion, early glomerular leakiness, often begins to improve. Uric acid levels can drop noticeably if you've reduced red meat, organ meat, and fructose-sweetened beverages. High-sensitivity CRP typically begins to show movement within 4 to 6 weeks of consistent anti-inflammatory dietary changes. This is measurable. This is the point to have the conversation with your doctor about adding the expanded panel to your next labs. At 2 to 3 months, the gut microbiome has had time to begin reorganizing around the increased fiber. The research on microbiome adaptation to dietary change shows that meaningful compositional shifts occur within 6 to 12 weeks of sustained dietary modification. This means the gut-kidney axis is beginning to shift, less indoxyl sulfate production, less p-cresyl sulfate reaching the tubular cells. This doesn't show up on a simple blood test, but it is happening at a biochemical level that matters for the 10-year trajectory of your kidney function. At 6 months to 1 year with consistent adherence, studies of comparable dietary interventions in people with early-stage CKD show that eGFR decline can be significantly slowed, potentially halted or modestly reversed in early stages. The Italian landmark bicarbonate study from 2009, which I'll mention briefly because the concept is relevant even though it tested a supplement rather than whole food, showed that a nutritional intervention targeting kidney acid load slowed CKD progression by approximately 2/3 over 2 years in patients with stage 4 disease. If that kind of impact is possible at stage 4 with a single nutritional variable, the potential at stage 1 or 2 with a comprehensive multi-mechanism dietary approach is substantial. I want to be honest about what these changes will not do. If you have stage 3 or 4 CKD and your eGFR has been declining for years, dietary changes are not going to restore you to full function. That is not what the evidence promises, and I won't tell you it does. What the evidence does support is that the trajectory of decline can be significantly influenced by diet, that what you do in the next 6 months affects where your kidney function is in 5 years. The window where dietary intervention has the most leverage is now, when eGFR is above 45, when the damage is early, when the repair mechanisms are still operable. This is the conversation that should happen at 50, not at 65, when the eGFR has already dropped to 35. Here is what the system has been telling you about kidney health. Manage your blood pressure, control your sugar, drink water, avoid NSAIDs. That advice is correct and incomplete in equal measure. It treats the kidney as a vulnerable organ that needs to be protected from insult. It does not treat the kidney as a dynamic organ with active repair mechanisms that can be turned on or off by what you eat. The 2024 Journal of Clinical Investigation Research on the Macula Densa changed my framework for thinking about kidney health. Not because it gave us a magic intervention, the human clinical validation is still ahead of us, but because it changed the question. The question is no longer only how do we slow damage. The question is also, what are we doing that might be suppressing the kidney's own capacity to repair itself? Excess sodium suppresses that capacity. The evidence says it clearly. The 2023 BMJ meta-analysis of 25,000 people across 12 countries changed how I talk to patients about fish. Not fish in general, marine omega-3s specifically. The distinction matters biologically, and the system doesn't make that distinction when it says eat healthy. The ERIC cohort, following nearly 15,000 people for 23 years, changed how I frame dietary decisions for people in their 40s and 50s. The choices you are making right now are writing the story of your kidney health in your 70s. The system does not present it that way. You've spent years in appointments that ran 12 minutes with a doctor who ordered the standard panel, told you your numbers were fine, and sent you on your way. The creatinine was normal. The blood pressure was being managed. You were doing what you were told. What you weren't told is that the creatinine becomes abnormal after half the kidney is gone, that the blood pressure medication was not addressing the underlying dietary drivers of kidney filtration stress, and that the foods you were eating every day were either suppressing your kidney's repair systems or supporting them. And no one ever had that conversation with you. That is not a conspiracy. It is the natural result of a medical system built to respond to disease rather than prevent it, and optimized around interventions that can be standardized, reimbursed, and scaled, which means pharmaceuticals and procedures, not 45-minute dietary counseling sessions. You can be frustrated by that system and still use it well. Get the labs I described, have the conversation, bring your doctor information from peer-reviewed journals. The best physicians I've interacted with over my career are not threatened by informed patients. They welcome them because it means the visit is productive, the patient is engaged, and the monitoring is real. Start with 2 things this week. Ask your doctor for cystatin C and a UACR at your next visit, or call the office and request them now. And buy a container of frozen blueberries. That's it. Those 2 actions put you further ahead than 90% of people your age in terms of kidney health awareness and early protective action. The evidence is on your side. The biology is on your side. The research from USC to the British Medical Journal to Johns Hopkins is telling the same story. Your kidneys have more capacity to maintain and repair themselves than the standard medical narrative acknowledges, and the food you eat every day is either activating that capacity or suppressing it. You have more control over this than you've been led to believe. Not complete control. Genetics and age matter, and there are conditions where medical management is essential and urgent. But within the range of what dietary and lifestyle choices can influence, the range is wider than most people are ever told. Leave a comment telling me what your doctor said about kidney function at your last physical and whether any of these markers were included in your panel. I read those comments. They help me understand what the gaps actually look like in the real world and what I should focus on next. This is Dr. Harris. See you in the next one.